would be speaking to us on retinal biopsies in uveitis. Over to you, Mohit.
Thank you, ma'am. Are my slides visible and am I audible?
Yes.
All good.
Thank you. Thank you. At the outset, I'd like to thank Professor Vishali for this very kind introduction. And I'm going to speak to you on retinal, and I added the term chorioretinal biopsy in uveitis. Just a couple of quick slides, and then I'm going to be discussing 4 cases and predominantly show surgical, steps and maybe a few pearls as to how to go about this seemingly challenging surgery. So vitreous and subretinal biopsy, pretty much you resort to them when there's a diagnostic dilemma despite clinical exams or logical tests, and you pretty much don't know what's going on, or there is dense vitreous inflammation which precludes posterior segment examination or adequate evaluation. Also, if there is a very high index of of a neoplastic or an infective etiology, or there's rapid deterioration of vision or worsening of inflammation despite adequate systemic steroid therapy and immunosuppressive agents, and especially for subretinal and chorioretinal biopsy, if the patient's already undergone a vitreous biopsy and the reports have been ambiguous, that's when one would want to or might think of resorting to a more invasive procedure. So, there is some data on this. I'm not going to go too much into data, but just quote this one paper, 2018. They did a review of all the published data on diagnostic vitrectomy for uveitis, which included some patients in some series which had retinal biopsy and some which didn't. So even after all of this, they had less than a 50% positivity rate as far as the diagnosis was concerned. Out of these 44% in which a diagnosis was made, most had an infective etiology followed by lymphoma, which is one of our commonest masquerades that we tend to see, and the common infections seen were herpes viruses, toxoplasmosis, toxocara, TB, and so on. However, this is a much more invasive procedure, in which there's a cutting of the retina, cauterization, and all of that involved. Hence, carries a higher complication rate with retinal detachment to the tune of up to 10%. And although it might have therapeutic benefits as far as visual acuity improving, but it also does carry with it, its risk of complications. So we have a couple of papers on this. I'm not going to get into this too much, and straight away dive into first of my 4 cases, in which this was a 62-year-old male. He had diminution of vision in the right eye for the past 3 months, which was insidious in onset, gradually progressive, had floaters, and was being treated as a choroiditis elsewhere with oral steroids with no improvement. So when he came to us, he had very poor vision in the right eye, hand motions, had a relative afferent pupillary defect, 2+ cells and flare, had vitreous cells. The left eye also had some cellular reaction, but that's what the photo at presentation was. The top one is the right eye, and you can barely make out the disc. All of these dull yellow kind of deposits under the retina, covering all of the macula, also extending extramacularly. And also in the left eye, you can see that it's, just temporal to the macula, and the corresponding autofluorescence showing the leopard skin appearance, giving a very high index of suspicion of this being, clinical suspicion of this being a lymphoma. That's the montage of the right eye. You can see there is optic disc edema and all of that. A plethora of that yellow subretinal deposit with overlying hemorrhage. And kind of a similar picture in the other eye. The OCT actually showed you those, in the right eye, those huge sub-RPE mounds, those ISO to, hyporeflective mounds, and which were, actually better appreciated in the left eye, which had less of that material. So with a provisional functional diagnosis of a lymphoma, of course, we had to prove it. So this patient actually they had disc edema, and as part of the protocol, underwent a CSF tap, which was not contributory. The MRI brain, the report came back just as microangiopathic changes, and it was not suggestive of a CNS lymphoma. So this patient was actually taken up for a diagnostic vitrectomy along with a subretinal biopsy. So this is how it went. So standard 25 gauge 3-port setup was done, and initially the diagnostic vitrectomy was begun under air so as to get an undiluted vitreous sample. So you can see that those air bubbles show that there is infusion of air and not BSS, and the cut rate was down to 800 cuts per minute, and the assistant was manually aspirating the vitreous, while the cutter was very slowly cutting the vitreous so as to try and maximize the yield of lymphoma cells in the vitreous. So after about a 1.5 to about 1.7 ml of an undiluted vitreous sample was taken, the infusion BSS was actually switched on, and then a good, much more than a core vitrectomy was done, and we were able to actually get 2 to 3 up to 4 ml of undiluted vitreous sample so as to provide adequate substrate to run all of our laboratory tests. And you can see you can have those fish eggs remaining after you switch back from air to fluid. But I think getting that initial undiluted sample under air is of paramount importance, because it increases the yield tremendously. So that's the higher magnification view, and you can see those deposits right there, which are right under the fovea as well, and hemorrhages overlying it. So now the subretinal or the retinal part of it, you can see that leopard skin appearance. We use the endocautery to make a single opening at the adjacent of the what looked like the uninvolved and the involved retina, and using a 25 gauge soft tip, which was just attached to a 2 cc syringe with the plunger removed. So basically a passive soft tip. We wanted to aspirate out some of those subretinal lymphoma cells. And you'll soon see that it was fairly easy, because these cells tend not to be adhesive. They are pretty loosely kind of packed together, and will easily, by the passive capillary action of the 25 gauge subretinal position of your soft tip, just kind of flow up the 25 gauge soft tip into the lumen, and then that's the sample that you can send, and the yield from that sample is going to be pretty good. So we could actually milk out a lot of those, as you can see. I'm just kind of pushing this video forward. So by the end, we were actually able to get a pretty good sample. We ended up doing endo laser to that site, and actually I left this patient with SF6 gas, and closed with sutures. So what actually, sorry, yeah. So actually, the cytology showed the vitreous, both the undiluted and the diluted. The report came back that it was a very low yield, which had degenerated lymphocytes and smudge cells. However, the subretinal aspirate, which was the last part, the third sample that we had sent, had abundant atypical lymphoid cells, which had irregular nuclear contour and multiple prominent nucleoli, which were CD20 positive and CD3 negative, extremely suggestive of a B-cell lymphoma, just showing how subretinal component of the surgery pretty much clinched the diagnosis in this case. Because if this sample wasn't sent, purely the vitreous report of the diagnostic vitrectomy would have come back unequivocal and not helped us. Similar patient, similar kind of patient, elderly 56-year-old lady, had diminution of vision for 8 months in the right, 4 months in the left, had history of stroke with, left hemiparesis. And when she came to us, she again had pretty poor vision in the right eye, at counting finger at 2 meters. The left eye also had diminution of vision. However, she did not have a lot of anterior segment inflammation. When she came, that's what she had. She had some vitreous haze, had that yellow kind of deposit there, and the autofluorescence, you can see that leopard skin appearance going all around, which is a lot better appreciated in the left eye, which is in fact in the whole of the macula. So again, looking at all of that, and the angiogram actually showed that there was a petaloid pattern of leakage along with the other, leopard skin appearance and the disc edema. And normally, the conventional teaching tends to be that your masquerades, typically lymphoma, generally does not present with hystoid macular edema. However, we all know now that is untrue. As we have seen a few patients, and Dr. Jose Pulido has also reported a few patients in which patients of lymphoma actually presented with CME. So this is actually what the patient had. So again, this patient was also taken up for a diagnostic vitrectomy, and this is how it happened. So again, similar setup as last time. We began under air for an undiluted vitreous sample, the cut rate being low, and after the undiluted sample was taken, we shifted to BSS so that a good amount of substrate was available. This is similar to what we did in the last patient. So that's the undiluted vitreous biopsy happening. Now, we'll soon shift to the intraoperative OCT. And although that was the site that was too close to the fovea for us to actually get down and get it. And so it was thought to be counterproductive if you were to, uh, make an opening that far close to the fovea. So what we actually did was we looked at another site of this of any visible subretinal yellow deposit, and we had one superiorly, which we'll soon be able to see. So just this is the intraoperative OCT showing the CME, and we had that site superiorly right there, and we made a opening right adjacent to that with the endocautery, and again with a 25 gauge soft tip. You'll soon be able to see those lymphoma cells marching up the lumen of the 25 gauge on the intraoperative OCT. Um, if you would just keep looking in in that frame there, um, because this is a passive process. This does take about 15, 20, 30 seconds. But you have to be patient, and this just proves the intraoperative OCT just actually gave us excellent real-time information that those cells were moving, those microscopic cells, up the lumen into the as you can see there, all of those cells which moved into, and this is the appearance after we'd actually remove those cells. This was followed by endo laser, and again we closed this patient with SF6 gas. Again, this is what the report showed. The vitreous fluid had very, very scanty lymphocytes, and you can see, that's that. However, the subretinal aspirate had a plethora of cells. The yield and the morphology of the cells from the subretinal aspirate that we sent, I mean, is there for everyone to see. And again, this was CD20 positive and clinched the diagnosis of a diffuse large B-cell lymphoma. And if time permits, I'm going to just maybe show one slide. This is, courtesy Professor Ramandeep. So this patient actually had received Ozurdex elsewhere and was actually then sent to us. And when the patient came to us, this patient had multifocal retinitis lesions. The aqueous tap, was sent for PCR, and that it showed toxoplasma, positivity. However, 1 week later, despite being on therapy, this patient actually landed up with precipitous loss of vision to hand motions. And you can see you can't make out the retina anywhere, no no vessels or anything, because all of that is the thickened hyaloid on top. Um, and the thick and fibrous hyaloid with bleeding underneath it. So soon you'll be able to see that after we cleaned the blood, and we were able to actually get a better view of the retina and assess what's going on. You'll be able to see those multifocal retinitis patches, which are so uncharacteristic of toxoplasma. But of course, if you were to inject all of those, so multifocal retinitis patches, and the Ozurdex given elsewhere kind of just poured a lot of fuel to the fire, which was actually going on in this patient. Now coming to the chorioretinal biopsy part of it. So we actually earmarked this area in which we wanted to take part of the normal, the junction of the normal abnormal and the abnormal retina, and we actually marked that out with laser. We made a 20 gauge separate sclerotomy with the MVR, and you can see we're actually using a vertical scissors to enter through that. This is our old school 20 gauge scissor, and this was actually used to cut out the edges that we had marked out, partly with cautery but majorly with laser, so as to achieve as decent a hemostasis as we could. So this was actually used to actually cut out that square in this patient, which involved what looked like the normal retina, the junction of the normal and abnormal, and the involved retina. And after that was done, a non-tooth intraocular forceps, max grip in this patient, a max grip forceps was actually used to get the sample out. That was the first part of it. The underlying part will soon come out, which actually looked like the atrophic choroid, and we were actually able to get that out. And this was sent for histopathology, and although I do not have it here, to actually show, but this actually showed the presence of the toxoplasma tachyzoids with a lot of inflammation and necrotic cells and inflammatory cells. And this patient actually ended up doing well, because the diagnostic dilemma, however, for this patient, because of active retinitis and a pretty invasive surgery, we decided to put in oil, and this is what the patient actually had, sometime later. And eventually, although the vision wasn't great, but we had a diagnosis, and we were able to save the eye with the patient having a 1/60 vision. I think I'm just going to end with this. This is also the last part of my my last case. So this is again a 20-year-old male. He had this lesion there, huge mass lesion, and the ultrasound was pathognomonic. That was a typical cysticercosis. Though these are typically not difficult surgery. The cyst tends to come out of its by its own. However, in this patient, in this context, it didn't. It looked white and kind of rock hard, and if I can use the term, calcified, even clinically. But when I went in, you'll soon see how when normally cysticercosis surgeries tend not to be that difficult, how difficult that was. You can see that huge mass lesion nasal to the disc, and it actually caused traction reaching all the way up to the optic disc and even temporal to it. We had to get the lens out after doing a lensectomy. This is, there was some bleeding. Getting this, so there was no way to cut or get that tissue or that structure out. So that actually extended all the way up to the ciliary body, in that entire quadrant. And a cutter, a forceps, a scissors all failed. So 2 hours later, I actually had to resort to making an ICCE incision, and this had to be delivered out like one of those humongous brown cataracts, as you can see, because it was just so calcified. You can see, I'm actually enlarging the incision and holding it with my 20 gauge foreign body forceps, because nothing else would hold it, and delivering this out through, as you'll see, um, one of the larger incisions I've had to make, I must add, since my residency days, when ECCE and ICCE were, well, not ICCE but ECCE were done. So this was actually delivered out through that. So this actually turned out to be another chorioretinal biopsy case, and I'm just going to and we finished this patient with oil. That's what this whole thing was. And we were able to give anatomic support to the eye. This is oil filled. That's the area of the eye, which actually we had some residual PFCL also, which was left behind. However, this patient had 2/60 vision, and that's what the histopathology showed. That's your entire cysticercus larva, which is kind of coiled up in, like, if I can use the term, a fetal position. And despite that really gory and pretty nasty looking surgery, I think we were able to not only remove the remove the lesion, but also save the eye and give at least some semblance of functional vision. Thank you.